Okay, cancer. We'll start first with the prevention, well, pathophysiology, and then prevention, and then move on to management. So you all familiar with cancer? Some of you more familiar than others. And for some, it may be close to home. Maybe you have someone, a friend or a relative that has dealt with cancer. So what do we always equate it with when we hear the word cancer? Yes. Okay. So let's say, who are moms here? Oh, Cornette, you're a mommy, right? Okay. So let's say your doctor says, okay, tells you today, okay, at 1 p.m. today, told you, oh, you remember that biopsy we did last week? You got the results and it's cancer. What immediately goes into your mind? Is it going to be about you or about your family? So I'm telling you now, let's say put yourself in that scenario. You're a mom, you have young children, yeah? Okay, and then the doctor told you the biopsy result is it's a malignant cancer in its stage 4. What will be the first thing in your mind? Will it be like your what? Okay. So are you amenable to, let's say, asking the doctor, oh, then what's the plan, doctor? What are the treatments, and then what are the success of these treatments? Are you amenable to that today, like at 1:35 p.m.? How much? Okay, that's a possible question. Yeah, but nowhere near like you're being receptive to the plan, right? All you think about is right, because we automatically think, oh, this is not good. Okay, I'm probably gonna die. Okay, and then you'll deal with the other stuff later. So you're always gonna think about what will happen to my kids. Okay, who's gonna take care of them? What resources do I have? Do I even have life insurance? Am I even insurable? Okay, so things like that. You always think of the worst. So let's assume our patients are thinking exactly the same way. So that's why on the first part, for the first hour, we'll include also how to explain to the patient the diagnosis, meaning we have to know what the diagnosis means. That means we need to know the meaning of the staging of the cancer, because who will be there when the patient, let's say in Cornette's case, so she experiences anticipatory grief, right? Meaning, what are the stages of grief? Yeah, denial, anger, bar bargaining, and then there's depression, and then acceptance, right? Okay. So, and we don't know how each person goes through the stages, right? So each person's different. So therefore, do we know exactly when that patient will get into the acceptance phase and then finally be able to, receive teaching and discussion? No. And the doctor is not going to wait. His doctor has to move on. After they tell the patient the diagnosis, they have to move on to the next patient, right? Deal with the next patient. And then, so who will likely be there when the patient actually hits the acceptance and then is open to education? Okay, so that's why we need to know what the diagnosis means, okay, and then what the treatment entails. Okay. So for this chapter, we're not only doing chapter 12, but also American Cancer Society. So we'll look at especially the prevention, okay, because there are mandatory, no, I don't say mandatory, well, mandatory for the insurance company to cover. Okay, so the American Cancer Society being the master or the expert on cancer, it's a government entity, and so they are the government, and the textbooks also refer or defer to the American Cancer Society recommendations. Okay, so whatever ACS says will go. If insurance companies, including Medicare, Medicaid, are obligated to follow their guidelines. So we have different types of cancer. We also have different causes. Some causes we don't even know about yet. things we are using or consuming today may be declared cancerous later. Okay, as in the case in California, they have the longest list of cancer-related substances. So let's talk about benign and malignant. So what's the difference between the two? So we have a table differentiating them. I wish there was a fourth column, like in the center, comparing it with the normal cells, but we're stuck with this. So let's look at table 12-1. So this is answers one of the bullet points on your exam blueprint that asks, what is the difference between a benign and a malignant tumor? So cell-wise, meaning the shape of the cell, the cells in benign are well differentiated. What does that mean? When it's well differentiated, that means it has a particular function. Okay, so benign tumor cells actually, and they resemble normal cells, so therefore they have a function. Okay, they can function like normal cells, whereas the malignant cell are undifferentiated, meaning they look nothing like a normal cell. They have resemblance, okay, a few characteristics, but the shape, the nucleus size, they're not the same. So therefore, do they perform any particular function? They're just there for free food and lodging. That's all they do. They do not give any benefit to the body. Mode of growth. In benign, the growth is fast, grows by expansion. However, it still has contact inhibition, meaning what is contact inhibition? This is a property of normal cells wherein when it hits a wall, it stops dividing. Have you noticed when you have a wound and then a scar forms, the scar doesn't go beyond where the skin normally was. Yeah, it stops at a certain point. Yeah, so that's what we call contact inhibition, meaning a normal cell, and it includes a benign cell also. When they hit a wall, meaning they hit somebody, another cell, that's their signal that, oh, it's time to stop. Okay, it's time to stop. However, they do expand, meaning, yes, they hit something here, but if there's still space up over here, they'll keep growing over there. Okay, so they expand. And because they expand, even though they hit something, as long as there's still room to move, they'll keep growing. All right. However, they cannot infiltrate surrounding tissues, so therefore they cannot spread. That's one thing good about benign tumors. Yeah, they'll grow by expansion, but they cannot spread. Meaning, if you have this tumor in one body organ, it can't go to another body organ. Does that make sense? Okay. However, it can still kill a patient because of the expansion. So let's say it grows in the stomach, in my abdominal cavity. I have a tumor here, a benign tumor. Can it expand and not harm me? Yes, for a number of years, probably, as long as I have space. Okay, I'll live, right? Because it won't really kill me right away because it's not infiltrating other organs. It's going to be bothersome, may cause constipation, for instance, or other GI issues because it's going to compress the other organs, right? So it'll compete for space. But however, if it grows in my skull, can it kill me? Yes, now because it will impair circulation to my brain tissue. That's a different story. Okay. Look at the malignant. So it doesn't only stop, no, because it has no contact inhibition. So therefore, it doesn't stop where there's a limit. So let's say it hits something. Okay, so there's nowhere to go. I'll enter the circulation. So they'll enter the arterial, venous, or even the lymphatic circulation and go somewhere else. Okay, so they're not limited to one body system. So they'll spread. Hey, no more space here. Okay, I'll go find other spaces to grow. Okay. Rate of growth between the two. For benign, the growth is slow, but it's still higher than the normal cell. Whereas the malignant, unregulated expansion, unregulated growth, really fast, unstoppable. When we say anaplastic, that means it has no particular shape. Normal cells have a distinct shape. Okay? When we say anaplastic, then that means they have no determined shape, meaning each cancer cell from another cancer cell, they'll have different shapes, okay? Undifferentiated. Metastasis. Like I said, benign tumors cannot metastasize. They are stuck wherever they are. If you remember here, it says here, they're usually encapsulated. That prevents them from infiltrating other body tissues because there's a sac, there's some kind of membrane causing or preventing them from invading other tissues. Yes. Well, both are cancerous. Don't get me wrong. Benign and malignant, they're both cancerous. It's just a matter of, huh? Yeah, they were talking, this is chapter 12. This is cancer.
I was thinking about tumors.
Yes.
They're both
Yeah.
cancers.
Yeah, they're both cancers, but cancers can be benign or malignant. And we're describing here what their characteristics are. Are we okay?
Can you explain more about
Okay, again, metastasis is spread, meaning it will, yeah, it will spread beyond wherever they grew initially. Meaning,
cells they are spread.
Yeah, they can enter, like I said, they can enter the bloodstream, arterial, venous, or lymphatic circulation, and then travel elsewhere. When that happens, though, that doesn't mean the patient has multiple cancers. Okay, that means they have the same cancer, but multiple tumors. Does that make sense? Meaning there's a primary tumor and there are 2 or more secondary tumors. Okay, or secondary tumors are also called metastatic tumors. So if you have multiple tumors in your body, what the doctor will usually do is take biopsies of each tumor that they find. If they all look the same, how many cancers do you have? 1. You have 1 metastatic cancer. If you have different types of cancer, when they look at each tumor, and they all look different, then you have multiple types of cancer.
And you said the secondary is also called
Metastatic or secondary tumors.
How you figure out these different cancers?
Again, the shape. Here, we look at the biopsy. We look at them under cytology.
Metastasis, it's one tumor, like it's the same cancer if it's migrated.
Yeah, if let's say you have a tumor in your breast and then there's a tumor in your liver. We took biopsies of each one. It's the same thing. Okay, they look the same, so it's the same cancer. General effects. So if it's localized, usually which is the property of benign tumors, they're usually found in just one body system. So of course, the effects will be more localized. Whereas if it's malignant, since they spread, then the patient will have systemic effects. Now, don't confuse effects with manifestations, okay? So the manifestations will be, of course, can be systemic because the patient has the human body will respond. Let's say the tumor is so big. So how much oxygen and sugar is it consuming? A lot. So now it will deprive the rest of the body with those nutrients. Does that make sense?
So like something can be benign, like benign tumor in the stomach.
Correct.
And it starts to block circulation. So now the legs now
Correct.
start becoming without
right.
oxygen.
Exactly.
Okay.
Yes. Yeah. So there are sets of signs and symptoms for the cancer itself, and then there are also complications, okay, related to the growth of that cancer. Tissue destruction. So again, benign tumors don't usually destroy stuff unless, again, the location interferes with blood flow. The example I gave you was if it's a benign tumor, however, it's growing in the skull, so of course it will damage the brain. Okay. But if you put that tumor somewhere else, let's say in the abdomen, it will cause less less damage because there's room to grow in the abdominal cavity. Does that make sense? Okay. And for malignant, because again, they have no contact inhibition, they invade tissues, okay? They rob normal cells and organs of blood flow, then they will destroy normal body systems or body tissues. Ability to cause death, again, benign depends on the location. Where is this benign tumor growing? So yes, it can kill depending on the location. Whereas the malignant, all of them will cause death.
Wait, they all cause
Sorry?
death?
We'll go to management later. All right, carcinogenesis is meaning carcino, meaning cancer, genesis. How are they created? Okay, how did they come about? Now, this part is not really testable, so I'll make it simple. Okay. We have cancer characteristics. Imagine when Michaela was conceived, so she was an egg, right? She was an egg from her mom. Mom ovulated, and then dad, said to his mom, "Hey, sup?" And then her mom said, "Nothing, sup?" And then, long story short, Michaela was conceived. So from one single cell, Michaela became 2, became 4, became 8 in seconds, right? So how do you describe that method of growth, that pattern of growth? Isn't that sound like cancer? Yes. So all of us have cancer characteristics. Yeah? Okay. So during embryonic up to fetal development, we divided like cancer, right? Our growth was exponential. Okay, so plus, in fact, look at your first year of life. You triple your birth weight. You double your height in your first week of life. Doesn't that sound like cancer?
Yeah.
Yes. However, your cancer characteristics should die down as you grow. All right. Meaning we have cancer tumor markers. Examples are alpha-fetoprotein, for instance. If found in large amount in an adult, that's a sign of cancer. CA19-9, CA125. So we have several tumor markers that, yes, they are found in a embryo, but they should not be found in high numbers in a grown-ass individual. Does that make sense? Yeah. That's okay. I'm not testing them. I'm just giving you examples. Okay. Now, so therefore, we'll divide the genes into 2. So we during our embryonic and fetal development, we have a gas pedal, and then we have a brake pedal. So we need these. So let's just call them, the gas pedal would be oncogenes. Oncogenes meaning cancer genes. And then we have suppressor genes, which is like the brake pedal. So in order to develop, we need the oncogenes. Okay, they help us grow. They help us develop. Imagine again, Kayla was just one cell. Now this amazing one cell became a complex human being, right? So therefore, we needed those genes in order to develop, right? And then, however, at a certain time, suppressor genes must take over. They have to stop it, okay? So that's the best way I can describe cancer. So as long as there's a balance between oncogenes and suppressor genes, there will be no cancer. But remember, we are made up of cancer-like cells, meaning we have oncogenes, okay? So how do we develop cancer then? We only develop cancer once we are exposed to carcinogens. Does that make sense? Okay. Now the list of carcinogens is endless. Like I said at the beginning, some we know, some we are yet to discover, right? So after exposure to these carcinogens, then that will determine whether or not we will have cancer. Does that make sense? Okay. So therefore, the cell mutation depends on exposure to a certain type of or types of carcinogens. So what are these carcinogens? First set are viruses and bacteria. So we discovered like the HPV virus has been linked to cervical and head and neck cancers. Cervical meaning the anal cancers or vaginal cancers are also linked to HPV. Hepatitis B has been linked to liver cancer. Epstein-Barr virus, Burkitt's lymphoma, etc. So therefore, when we get to the prevention, can we prevent cancers with vaccinations?
Yeah.
Yes. Therefore, if you take the HPV vaccine or the hepatitis B vaccine, are you therefore protecting yourself from these cancers? Okay. So here, bacteria, these had been linked also to these types of cancers. Okay. Now, physical agents. So examples are chemicals. Industrial chemicals, asbestos has been linked to mesothelioma. Okay. And then tobacco, not only to lung cancer, tobacco has been linked to multiple types of cancer beyond larynx and lung cancer. Ultraviolet rays. Okay, so that's why we're advised to wear sunscreen. Okay, so otherwise we could develop melanoma. And we move on to, besides the physical agents, you know, the diagnostic radiation or therapeutic radiation, okay, or industrial radiation also. Okay, those used for power plants or for weapons, for instance, nuclear weapons. Okay, these are all radioactive material. That's why your X-ray technicians, for instance, CAT scans, they always wear shields, right? They wear aprons. And also, it's been known that, let's say, if you receive treatment for a radiation treatment for one type of cancer, the doctor tells you ahead that maybe years later, you will develop another type of cancer as a result of the exposure to this type of radiation, okay? Chemicals. So we already talked about tobacco. And look at this. Tobacco has been linked to larynx, pharynx, nasal sinuses, brain, bladder, rectum, stomach, and breast cancer. Okay? A lot of cancers. And tobacco is found in these products, so not just cigarettes. So hookah also have tobacco in them. Okay? And we don't know yet about vaping. We'll know maybe in 10 years once we have enough data, but right now, nothing yet. For table 12-2, let's keep this simple. So if you look at the names, the suffix actually, to be particular, the suffixes, you know what a suffix is, right? The end, okay, the end of a word, okay. So this one, for instance, is carcinoma, okay, sarcoma. So when they end in sarcomas or carcinoma, let's say adenocarcinoma or osteosarcoma, these are malignant tumors. Okay. Of course, to combine the word, you have to add a root and a prefix, right? So let's say adeno sarcoma, that means it's a adeno is the adrenal glands, okay? So that's an example, adenocarcinoma. Or osteosarcoma would be the bone, okay? All right. So in general, when we have OMA, for instance, except again sarcoma and carcinoma, when you have an OMA, for instance, myoma or let's say lipoma, if it's just OMA, that's usually benign, except melanoma. Melanoma has no benign form. Melanoma, all types of melanomas are malignant. So OMA, usually benign, and sarcomas, carcinomas, always malignant. Yes.
Yes. Oh my, benign. So if it was osteoma, it's something like that.
Yeah,
As opposed
Usually
to
benign.
osteosarcoma.
Yeah.
Or
so something that ends with this suffix, carcinoma, sarcoma, are malignant. What's hard about that?
But sarcoma, carcinoma, and melanoma is malignant.
Yeah, melanoma. I know melanoma ends in oma. However, there's no benign form of melanoma.
That's a skin.
All right, lifestyle. Okay, so obesity, alcohol intake, it's severe, heavy alcohol intake, poor diet, physical inactivity. So they still account for about 16% of all cancer cases, meaning they increase your risk of developing cancer if you have these lifestyle characteristics. And hormones, we know that certain cancers feed on body's hormones. For instance, most breast cancers feed on estrogen, for instance. Okay, so that's the more we know about these cancers, then we devise ways to treat them. Let's say we give the patient tainted hormones. Okay, we use hormone therapy, which are tainted with chemotherapy, for instance. That when you give it, then the cancer, of course, will swallow it, right? The cancers love that hormone, they'll gobble it up, but then it already contains chemo, so they die, right? So, no, sometimes we use the cancer characteristics, okay, to help treat them, okay? Like say, for example, I've read about this cancer doctor that operates in Tijuana. He's American. He's board certified, but his methods were not approved by the FDA because it's dangerous. So he can't practice in the U.S. He practices in Mexico, who is approved his method. So patients would flock there to get his treatment. His style was or is, because he's still there, is because all types of cancer are hungry for sugar, right? That's a fact, meaning they eat large amounts of sugar. So what he does was he'll give the patient massive amounts of insulin, drop the sugar to dangerously low levels like 20 or less. So, and then he'll give the patient massive amounts of sugar that is tainted with chemo drugs. So of course, the cancer cells are the ones that will eat most of it, right? Yeah, of course, it will affect normal cells also, but majority will be the cancer because now you starve them. So now they're gonna be super aggressive, right? Let me have that. Okay, and then they'll kill. Okay, but again, it's a very dangerous method. So he has a ICU type setting. He has very good nurses, but again, his method is just way too dangerous. So that's why he didn't get FDA approval. Okay.
Until one of their family members needed to be flight into Tijuana.
Yeah, he's still in practice. I know because my brother, when he was still alive, brought patients to him. Yeah. No, these were people who, these are people who are like desperate. Like they've been treated. The cancer came back, or other doctors had turned them away, gave them a few months to live, and then obviously these are rich folks, okay, who have a lot to live for, a lot of money to lose, so they're desperate. They go to him, and then some survive, others did not. For the immune system, so we know that the immune system fights cancer. Best evidence is in HIV positive people, most likely AIDS. So AIDS patients develop Kaposi sarcoma, correct? Therefore, if you develop cancer because you have immunosuppression, therefore, or immune deficiency, therefore, your immune system can kill cancer cells, right? That's the logical conclusion. So if you're immunosuppressed, therefore you're at risk for cancer. And we also have immunotherapy today, right? So we're using your immune system to fight cancer. Okay, so only for certain types of cancer. All right, that's about it. Let's go now to prevention. There are two levels of prevention. We have primary and secondary prevention. Tertiary prevention isn't really prevention, but it refers to surveillance of people who survived cancer, meaning after you've been successfully treated for cancer, we continue to monitor you for either the recurrence of that same cancer or the development of another cancer. Okay, so that's tertiary. We'll focus only on primary and secondary. Primary prevention is reducing risk of disease through health promotion and risk reduction. Again, what is it about? Reducing risk and risk reduction. Okay, meaning what would be under here? So examples given here are smoking cessation, vaccination, okay, sunscreen, for instance. These are all primary prevention, meaning you're avoiding the risk factor. Okay, what's under here again? Reducing risk. That means if you're smoking, what do? Stop. So that's reducing the risk, right? Or let's say you're fond of having steak every night, and we know that fat and red meat are high risk for cancer. So if you cut down, to just once a week maybe, so that's under primary prevention. So you know that the sun UV rays are cancerous, so you sunscreen. So you get the idea? Okay. So it's all about reducing risk, and risk reduction is the same thing, yeah? And health promotion, of course, is eating healthy, right? Eating vegetables, fruits, okay, high fiber. That's all under primary. So what's under secondary?
Screening.
Prevention. Early detection and screening. Okay, so therefore, breast self-examination, is that primary or secondary?
Secondary.
That's secondary now. Testicular examination, secondary. Do you see the difference? Okay, so in primary, you're trying to avoid both are prevention. Okay, so in primary, these activities involve reducing or avoiding the risk altogether. Okay, you know what's causing cancer, so you avoid them. Okay, that's primary. Secondary is early screening and early detection. You see the difference? Okay, so here you may have it already, but we're trying to detect it early. Okay, screen it early, diagnose it early. That way, your survival is higher. Okay, so therefore, we only use one or both strategies, both primary and secondary. Okay, now let's go to the. I won't use this textbook because it's when was this published? 2021, I think. I think this is 2021. So it's old. Okay, so the American Cancer Society website updates periodically. Okay, there was one semester I remember in 2016 wherein I had a class today, and then 2 weeks later the ACS changed the recommendations. All right. Okay. So let's go to the ACS website. So we'll disregard the screening guidelines mentioned here. Okay, this is now too old. Okay, a few may still be. No, not this chart. This chart is for nutrition, so this one applies. Okay, this never gets old. Please read on your own. They're self-explanatory. I won't waste your time on that. Let's go to the, and I already explained tertiary prevention. Let's go to the website. So you type in cancer.org. Cancer.org. So this is the American Cancer Society website. Don't worry about the homepage because this changes like every week. Okay, so they may look like this today, next week it'll look totally different. Okay. So where do you find the guidelines? Go to the menu here. Sorry, bear with me because it's again because the website changes all the time. Okay, so right here, just scroll down to where you see prevention. But you don't go specific. Let's go to the guidelines. Okay, so let's try get screen. So after I click get screen, let's go to cancer screening guide recommendations. So this one is by age. So that tells you what is the number one single most important factor of cancer prevention, or number one single most important or most common risk factor for cancer. Age. Okay, so as we reach a certain age, we become susceptible to cancer. Does that make sense?
Yeah.
Okay. All right, let's start this one because this is the easiest way to do it. So how did I get here? Okay, let's start over. So from the home page, I went to under risk prevention and screening. I clicked on get screen. Okay, I clicked on get screen. And took me here. And then you scroll down onto cancer screening recommendations. Okay, so it divided it by age. So therefore, when is the earliest age we start screening for cancer? 25. Okay. This changes, like say, let me explain. Let's say in 2008, okay? Yeah, the first year I started teaching, 2008. When I went to the website under cervical cancer screening, the recommendation was all sexually active women should start screening for cervical cancer, meaning all sexually active women had to have a pap smear, meaning if the 9-year-old is sexually active, they start screening at 9 years, all right? And it evolved. From 9 years, it changed to 18. And then later it's changed to 21. And then finally we're at 25. So that means what made the guideline change? Data. Okay, data. So as the American Cancer Society started gathering data, they changed the recommendations. Does that make sense? Okay. This is scientifically based on, right? So it's not some doctor's opinion. Okay, so this is from statistics. Okay. So 25 to 39, they came up with that age range because that's the based on statistics again. So most people who had the first diagnosis of cancer were between 25 and 39. Okay. So again, what are these recommendations? Okay, look at the statement here. These recommendations are for people. Read that. Are you on the website?
Yeah.
Read that for me. Okay, so if you're above average, meaning you have symptoms, you are bleeding between your periods, you have pain in your pelvic area, you have pain with intercourse, are you at average risk?
Yeah. Above average.
No, you have
Average
symptoms.
is
You're
just
not
the-
average risk. Okay, does that make
Average is
sense?
just the
Okay,
age.
so these are people who have no symptoms of
Mhm.
cervical cancer, meaning they're average risk. What if your mom had cervical cancer? Are you at average risk? No. So do these guidelines apply to you?
No,
No. Are we clear here?
yeah.
So before you start questioning, oh, this is ridiculous. This is only for who? Average risk for cancer. Are we clear? Of course, if you have symptoms at 13 years old, do you wait until 25? No, because this doesn't apply to above average, higher than average risk for cancer. Do you understand? So what is this only for?
Average.
Those at average risk, meaning let's say right now, you're who's 22 here. You're 25?
It's 21.
22? Okay, so therefore, you have no symptoms. Are we gonna screen you for? No, you don't qualify. You could, but you have to pay out of pocket. Does that make sense? You can if you want. Yeah, we'll give it to you, but pay up because the insurance company won't cover it unless you are 25 to 39. Does that make sense?
She's stressed, doesn't that add? Woman. I'm just saying, hypothetically, wouldn't stress?
What is your point?
The people with cervix, that's a woman.
Well, only females have a cervix.
That's politically correct, right? People.
Do you understand?
cervix.
Okay.
Yeah,
All right, let's not go there, okay? So for 25 to 39, what's the only recommendation?
Cervical.
Cervical cancer screening. Okay, 40 to 49. Oh, we have more now. So cervix is still there, but now we add breast and colorectal now. So the current recommendation for colorectal, I give you the example. For colorectal cancer used to be 50 in 2016. Now it changed to 45. So what do you think is the reason for the change?
Eating.
Again, data. So they're seeing, oh, nowadays we're seeing more 45-year-olds having colorectal cancer. Let's drop the age recommendation. All right. Okay. Who knows? I mean, things are changing, our eating habits, our foods are changing. So I don't know. We don't know what's causing the incidence of cancer. So for age 40, look at under breast, okay? 45, recommended at 45. However, females have the option to begin at 40. So at 40, let's say I'm 40, do I have to have it? No. But if I want to, and it's free. Are we clear? All right. But let's say at 45, should you? You should, okay? Because cancers.org said so, okay? American Cancer Society, every 45-year-old woman should begin. Yeah, so the screening here, of course, this is, you can either do the breast self-examination. Of course, this doesn't say female only, right? Because both men and women have breasts. So this will apply to both male and female. Okay, there are, although it's very rare that males have breast cancer, but again, it doesn't discriminate. Okay, of course, cervix, there's no cervix in the male anatomy.
Biological male.
Okay, let's go now to 50 plus. So 50 plus, we continue breast cancer screening, cervical cancer, also recommended, colorectal, continue. Okay, for smokers or ex-smokers, they begin screening for lung cancer at age 50. This one's easy though, because for smokers, the lung cancer screening is simply a CAT scan. Unlike here, cervical cancer, you have to go to a clinic and get a pap smear, okay, uncomfortable. Lung cancer, simply CAT scan. You lay down on the bed, you get a CAT scan. Okay. And then for the breast cancer, depends on the the practice that you go to. Some of them still have the non-3D imaging, meaning they have the panini, you know, they put the breast on a plate and then they make a panini out of your breast.
What if the breast doesn't-
Any breast will become a panini. These are machines.
I need to look that up.
All right, any question on the cancer screening? Okay, so let's go back here.
I need to look that up. Yeah.
You know what? I didn't share the screen, but you know where the website is, right?
Cancer.org.
Right. Okay, we'll do diagnosis and then we'll do we'll take a break. Staging and grading. So we'll use only the so skip table 12-13. Okay, this is not updated. Maybe it is, but I don't think so. The most updated, of course, will be the ACS website, cancer.org. So we can skip this table because this is basically at least 6 years old. Because if this was published 3 years ago, then that means they collected this 3 years before that. Okay.
Are you gonna test this on it?
Why would I bother taking you to the cancer.org website?
Oh, so you are gonna.
But not 12-2. 12-2 is obsolete.
Oh, that's. Yeah, so that's two is the types of tests.
Is that clear?
Uh-huh.
Just a warning on tumor markers. So tumor markers are, again, alpha-fetoprotein, CA129, CA125. There's others, okay? So there are several dozens of tumor markers. What are tumor markers? They've been known to increase or elevate in the presence of certain cancers. The problem with tumor markers is they're also present in non-cancerous conditions, meaning they're not exclusively present in cancer. So can we diagnose cancer based on tumor markers? No. However, can they assist?
Yeah.
Yes. They're only used, therefore, to assist in the diagnosis, but it cannot be the sole basis of diagnosing cancer. Your sole basis would be a biopsy. Okay, we have to actually get a tissue sample and then conclude, okay, yeah, based on this tissue sample, this is cancer. Of course, the imaging, you know, mammography helps us find the tumors, okay? PET scans, CAT scans, MRI. But again, we need a biopsy. But of course, all of these are needed in order to find the tumor. All right, chart 12-3. TNM classification. This is a universal staging classification for cancer. So meaning whichever country you go to, they use the same. So there's no differences in diagnosing your cancer. T stands for the tumor. Is there a tumor or not? How big is the tumor? Or is the tumor able to spread or not? Okay. N is the presence or absence of lymph node involvement. Now, why is it important? Because the lymphatic system is like a highway, okay, for the body. So if there's a lymph node involvement, that means, does this cancer have the ability to spread? Definitely spread. M would be the absence or presence of metastasis or spread. Let's start with the T. So TX is not good news. It's not bad news either. TX means we do not know. We don't know if you don't have it. We also don't know that you don't have it. Okay. So TX is nah. Okay. 0 is good because T0, we're sure there is no tumor. Okay. TIS, yes, there is a tumor, but is encapsulated. It's in situ. Okay, that's what in situ means. It's encapsulated. Okay, so therefore, is it benign or malignant? Benign. T1, T2, 3T, T4. There's no T2000. Okay, so 1, 2, 3, 4 is small, medium, large, really like damn large. Okay, this is not really made according to a certain number of centimeters. Okay, so this is very subjective because let's say a T4 in the abdominal organ, meaning a cancer, a T4 abdominal cancer, is it the same size as a T4 brain cancer?
No.
Of course not. Okay, does that make sense? Okay, so this becomes very subjective. Okay, so T1, you have an idea though, T1, oh, that's a small tumor. At least today, that's small. Or if the doctor tells you a T4, that's like, damn, okay, that's a big tumor. Yep. Lymph nodes. So NX the same. Is NX good or bad? We don't know. Okay, we don't know. There's no, the doctor doesn't know if whether or not there's lymph node involvement. What about N0? That's good. Yeah, we know there's no lymph node involvement. We're definitely sure. N1, 2, 3, of course, this will increase to 4, 5, 6. However many lymph nodes are involved will be written here. Okay. For metastasis, MX, what does that mean?
It is.
We don't know. We're not sure. Today, we're not sure today. M0, we're sure. You can rest assured there's no metastasis. Okay. M1, so this can be up to M7 because right, so there are on record the highest spread has been 7, meaning somebody had one cancer which has spread to 7 different organs, meaning let's say breast cancer, it has spread to the brain, the lung, the bone, the liver, and yeah, wherever else. Okay, so M7. So you're very lucky to be M7. Okay, woo. Okay, I got the record. Yes. Or let's say M8. Ooh, Guinness Book of Records.
Went outside.
Yep, you're gonna die. Yeah, don't worry. Everybody will die.
But you will die a record breaker.
Yeah, but you just look really